So I'm Dr. Haynes, Jeffrey Haynes. I'm a radiation oncologist, so I treat patients with cancer by using radiation therapy. I work at the Lipson Cancer Center, which is the cancer center of the Rochester General Health System, just on the other end of this building. And then we have another clinic out at the Linden Oaks Medical Campus where 490 meets 590. So I think Dr. Eddinghausen covered very beautifully that there are really two kinds of liver tumors. There are tumors that started in the liver, hepatocellular carcinoma, cholangiocarcinoma, and more commonly, livers that started someplace else and then spread through the bloodstream to the liver. So they're liver tumors, but they're not liver cancer. They're metastatic cancer from someplace else. So in order to help you to understand how radiation works, I want to talk a little bit about how cells multiply, and in particular about how cancer cells multiply. So this is a picture of one cell turning into two, which some of you may remember from high school or college biology. So if you have one cancer cell, and it decides that it wants to reproduce so that there can be more cancer cells, one of the very important steps is it has to get all of its DNA copied and has to get one copy into each cell. So your DNA is on 23 chromosomes, and we've got just two of them shown here in the picture to keep it easier to see what's going on. So the cell has made an extra copy of the blue chromosome and an extra copy of the orange chromosome. And then when it's time to divide into two, it has this pink structure that grabs hold of the chromosomes at the center and pulls apart the blue pair and the orange pair so that each of the daughter cells ends up with one blue and one orange. So the way that radiation kills cancer cells is by breaking the backbone of the DNA. So the radiation comes in, and radiation is made up of photons, high-energy X-rays. They come in and they can put a break into one of the backbones of the DNA, right? So all of your genetic material is in DNA. The information is in the nucleotides in the middle, and then they're all held together and held in order by the two backbones in blue. So if the radiation manages to hit both backbones close together, what you get is you get a break in the chromosome. The chromosome breaks into two pieces. And so what that means is when this pink structure grabs hold of the chromosomes at the middle, it's only going to get part of them, right? And so it's going to get only the bits attached to the little dot in the middle. And the other parts are just floating free in the cell. And the result is that it's actually very unusual for each of the daughter cells to get a complete set of DNA. Each daughter cell is going to be missing pieces of its chromosomes, which kills the cell and ultimately shrinks or eliminates the cancer. And it turns out that the cancer cells are dividing more quickly than your normal cells, right? This makes sense in the sense that the tumor is growing and the rest of you isn't. And that's because your normal cells only multiply. They only divide from one cell into two when the cell next to them has died and it needs replacing. Whereas cancer cells just divide and divide and divide and make more and more cancer cells. And so what that means is that the cancer cells have less time to fix all these breaks before they divide in two and have to have all of the chromosomes repaired. Whereas your normal cells have more time to repair the damage because they're not multiplying as often. They also happen to be better at repairing damage to DNA. So we've talked about why radiation works. I want to talk in particular about stereotactic radiation. So stereotactic radiation just means that the radiation is more focused than conventional radiation. So the radiation that we give for most patients, the radiation that we've been able to give for decades, uses a small number of large beams, and the result is that we end up radiating more normal organs. And so you tend to get more side effects, but less likelihood of curing the cancer. So I'm going to show you a number of pictures like this today. So these are CAT scans. So these are two slices, the same slice from a patient that we treated. So just to orient you a bit, a CAT scan is sort of like if we were to slice a person up like a bread loaf, take out one slice and then take an X-ray of that from above. That's pretty much what you'd see here in white and gray. So this is the front and this is the back. You can see the breastbone or sternum. Here's the spine. These other white things are the ribs. The black is the air in the lungs. This middle thing is the heart. And then over here is the liver. And then I've put a color wash on top of it to show where the radiation ends up. So the color wash is everything in color here. And basically, if things are getting the full dose that's intended for the tumor, then they're red. If they're only getting a little bit of dose, then they're blue. And if they're getting something somewhere in between, then they have a color from the middle of the rainbow. You know, orange being more radiation than, say, the green that you see here. And so I put this up to demonstrate the difference between conventional radiation that we don't use much in the liver anymore versus stereotactic, or more focused radiation. And you can see that the conventional radiation is using 1, 2, 3 beams, and it's delivering a lot of radiation on the way in. It's delivering a lot of radiation, a full dose to parts of the liver that aren't part of the tumor, which we've drawn in with this red line. And it's delivering a fair amount of radiation to other organs on its way in to hit what we're aiming at. And we'll talk a little bit more about that. So the stereotactic radiation is more focused for several reasons. One of those is because we're using more beams. So with our conventional radiation, we had 1, 2, 3 beams. To get this dose color wash, we've got 13 beams. I know this is a little hard to appreciate, but each beam is represented by 2 yellow lines, each of which shows the sides of the beam. So this yellow line and this yellow line are showing us the sides of a beam that's starting right here. And so if you kind of count up the start points, you find that there are 13 beams coming from all the way around. And this is why we're able to cut off the corners. Right? There are areas of the liver that are getting the full dose, not because we aimed at them, but just because we only used 3 beams. So the process of getting stereotactic radiation starts the same way as getting any kind of radiation. It starts with a CAT scan in the radiation department. The patient lays flat on their back, usually with their arms above their head on some hand holders to help them to keep their arms in the same position every day, and their elbows resting on these elbow rests. There are laser pointers that come out of the walls and the ceiling, and we actually put a tattoo where each of those laser pointers touches. We put a little dot of India ink, and then we prick the skin with a needle, and that makes a little permanent black dot. On this patient, we've put little stickers with BBs on them just to help us to see where those tattoos are when we do the CAT scan. So this is how any radiation starts. When we want to be more focused with the radiation, we add a few more steps to that CAT scan. So we make a custom mold that we shape around the patient. That's here in blue. It goes from the shoulders all the way down to the knees, and it's shaped up around to kind of wrap around the patient a little bit. And then we put some extra bars across, which are also shaped to the patient and help the patient to get in exactly the same position every time that we treat them as they were in when we planned the radiation, and that further helps us to be precise with the radiation. And the most important part is this plate right here. So there's a plastic triangle about that big, which we put on the patient's abdomen, and then we put some pressure on that triangle. And the result of that is that it forces the patient to breathe with their lungs, like this, with their ribs really, rather than with their belly, right? Because when you normally breathe, your diaphragm is pushing your liver down in order to make your lungs expand. And that's fine unless we happen to be trying to aim at something in the liver, in which case it makes the target move and forces us to radiate everywhere that the tumor could be while a person is breathing. So this plate ends up being pretty important. So this is another CAT scan, but this one is just a little bit different. It's a coronal slice, so we're cutting this way. So it's kind of a slice right from the middle of the patient. And to orient you a bit, these are the ribs here in white. The black is the lung, and then this gray here with the rounded top is the liver. So the red thing is the tumor that we're aiming at, and then the line around it is the target of the radiation, because we can't just aim at where the tumor was the moment that we took this CAT scan, because the tumor is moving up and down as the patient breathes, and the lungs expand and push the tumor down. So with traditional radiation, we have to add a lot of extra area to our target relative to stereotactic radiation with this compression plate. And the result is that we ended up radiating a lot of normal liver, which we can now avoid irradiating. So once we've done that CAT scan with all that stuff on, then we come up with an arrangement of radiation beams which is specific to that patient. So this is going back to the same patient that we've been looking at. We've made a 3-dimensional model of the patient, which is in beige, a model of the liver in blue, and a model of our target, the tumor, plus a little margin for errors in positioning and the movement that you still get, even with that plate on the belly. And then we've chosen the 13 beams that we looked at earlier, and you can see that they all converge on the target. We actually make models of all of the normal organs, but that would make the picture confusing. So once that arrangement of beams has been come up with, then the patient comes in generally for 5 treatments. And each time they come in and they lay on a machine just like this. So they lay right on this flat table here. And the machine moves around the patient. So you can see the head of the machine delivers a beam from one direction, then it moves a bit, delivers it from another direction, moves a bit, delivers it from another direction. But before we do that, we like to take an X-ray or a CAT scan to make sure that we've positioned the patient exactly right. And that's what this other bit is for. So this is delivering the really high energy radiation that cures cancer. This is kind of a lower energy radiation that lets us take pictures. And this is kind of like the film that we used to use. So, for example, this patient is receiving radiation to an area near the liver. And so this is the picture that we took when we originally had the patient positioned. And so we're using that for planning. And we know that we want the crosshairs, we want the aim of our machine to be over this particular spot on the spine. So you can see the multiple bones in the spine and then some ribs sticking out. And this is the picture that we took with this X-ray machine immediately before delivering the treatment. And it's maybe a little subtle from where you're sitting, but we can see that the crosshairs are about a quarter of an inch too low in this patient, or a quarter of an inch too low relative to where we want to be. And so all we have to do is we move the table towards the machine about a quarter of an inch, and the result is that then the crosshairs center exactly where we need them. So this is another technology that's made us much more precise with radiation today than we were 10 years ago. So the treatments are generally 5 treatments. It's generally over a week or 2, sometimes 2.5 weeks. The treatments are very easy. You come in, you lay on the table, we position all that stuff on you. It takes about 40 minutes total. The actual treatment takes maybe 20. People don't feel anything, they don't see anything. It's a lot like in a CAT scan with no contrast. People can drive themselves to the radiation, they can drive themselves home. They don't feel any different after the radiation than they did before. And you don't become radioactive from getting radiation therapy. You don't develop superpowers, and you don't pass any radiation to your children or other people that you're around. There are no special rules about needing to be isolated. So a lot of people ask me how they're going to feel during the week or 2 that they're getting radiation and the weeks after. And the answer is that most people get no side effects from this treatment because we're treating such a tiny area with the radiation. But it's not uncommon to have some fatigue, maybe want to take a nap in the afternoon, go to bed an hour early. And it's not rare to have nausea or vomiting or diarrhea because there's some radiation to the liver and also to the gut. But usually a little medication will control that. And so essentially, getting radiation, stereotactic liver radiation is like a walk in the park. So what lasting effects can you have from radiation? So most people will have no lasting side effects from stereotactic liver radiation, again because the dose is limited to a very small area. But side effects are possible, and it really depends where the tumor is within the liver, how big the tumor is, and how much dose we give. So this is a different patient than the one that I just showed you. It's another CAT scan slice, a slice this way. You can see the liver here. Here's the spine again. Here's the ribs. Here's the stomach. This is colon here. There's the spleen. So it's a relatively small tumor. And you can see that the area that's getting the full dose is really limited to the area we were aiming at. And the area getting kind of a middling dose is mostly just a little ring of liver around it. So we don't really expect a lot of side effects for this patient. But if the tumor were a little bit closer to the rib, then you can imagine the rib would be in the area that's, say, yellow or green and getting a significant amount of radiation, and there'd be some risk of breaking a rib. It weakens the ribs in a lasting way to give a lot of radiation to them. There's also a very small risk of getting lasting pain in the ribs. So these are concerns that we have, and when we decide who's a good patient to get stereotactic radiation, one of the questions is where's the tumor and how big is it? If the tumor is, say, right up against the stomach or right up against the intestine, we might need to back down the dose or maybe find a different way to treat the tumor, because if we give too much dose to those organs, we could cause an ulcer in the stomach or an ulcer in the intestine, which can cause pain. It can give you some bleeding as well. So that's something that we try to avoid. So people generally want to know next whether stereotactic radiation works, and the answer is that it works actually quite well. We're able to completely eliminate about 3/4 of tumors that we treat with stereotactic radiation, and that includes in the liver. This is just one patient that we treated, the one that I showed you first. So you can see, so to orient you again, this is a slice coronally, so it's a slice this way. And you can see the ribs, and here's the liver. There's the lung above, a little bit of bowel below. Here's a blood vessel in the liver. This gray thing is the tumor that we were aiming at with the first slides of the color wash that I showed you. And months later, there's really no tumor that we can see on our scans, so it's a pretty good result. So I want to kind of temper that just by pointing out that the results are better with a tumor that's smaller. Of course, there are fewer cancer cells, so we're more likely to wipe them all out. We're able to give more dose safely, and that also makes us more radiation safely, and that also makes us more likely to cure them. But how well a person will do depends on multiple factors. If there's really just one tumor, then curing that tumor is really a cure for that patient, and we expect them to live 30 more years, as long as they naturally would be expected to live. If there are other tumors other places, sometimes our goals are a little different. If we think the liver tumor is the thing most likely to cause problems first, sometimes we'll treat it, even though we know we're not going to cure them of cancer. And of course, those folks won't do as well as folks that had just one cancer in the liver. And of course, the overall health of a patient matters too. If somebody has a liver that's in very bad shape because of other liver diseases, like Dr. Ettinghausen talked about, there is some additional risk that they'll run into problems after radiation to the liver. Another question I often get is, there are a lot of options for liver tumors. Which one's best? You know, which one should I get? And there's not, the answer to which one's best really depends on the situation. And the most important distinction is between folks who have just a few tumors limited to the liver, say 1 or 2 or 3 usually. And for those folks, if they're well enough, and Dr. Ettinghausen or another surgeon thinks that they can get all of the cancer out, we generally recommend removing all of it with surgery. You know, my radiation cures 3/4 of things. A lot of the other options that we have cure a large percentage of the tumors you aim them at. But if you get all of the tumor out, you know, that's 100%. So other options for a tumor, just a couple of tumors in the liver, would be stereotactic radiation, like we just discussed, radiofrequency ablation, and cryotherapy, which Dr. Ettinghausen alluded to, and I think Dr. Pine may touch upon as well. Now, for somebody that has numerous tumors in the liver, though, it becomes impractical to try and cut all of them out or to radiate them, because you'll damage too much normal liver. And so if we have to give it, in that case, we need a treatment that can cover the whole liver without destroying the liver. And there are really three options for that. One is to do radioembolization, which Dr. Pine will touch upon in just a minute, where we inject radioactive beads into the liver. Another is to inject chemotherapy, which we've been doing less often since radioembolization came around. So that's injecting chemotherapy strictly into the liver. People need to be hospitalized and sometimes feel a little more ill than they would have with radioembolization, so we use it less often. And another great option for many patients is just simple chemotherapy given through a vein in the arm, which will treat everything in the liver and every place else. So particularly for somebody that has cancer in other locations, that's often what we'll start with, and we'll start looking at these other options only if the chemotherapy options become more limited because the tumor has evolved to grow in spite of them. So ultimately, you know, in order to really know if a particular treatment is the right one for you, you need to sit down with your doctor. And obviously, we're happy to have people taken care of by any doctor, but if you wanted to come to Rochester General, you could come and meet with me or my colleagues, Dr. Chawla and Dr. Atanas. We're posing here with our dear friend Bessie, our linear accelerator, which you might recognize from the earlier picture. Any questions? Please. I'm sorry, I should repeat the question. So she was asking, if somebody has a bunch of tumors in their liver and then they get chemotherapy and a lot of them go away, does it make sense to do something more focused for the remaining tumors? Because it kind of highlights the fact that for many people we're giving a combination of treatments. And so there are studies that demonstrate that in folks who had a lot of liver tumors and were able to eliminate a lot of them, say with chemotherapy or radioembolization, cutting out the remaining tumors, or if you're not a good candidate for that, then something like stereotactic radiation or ablation for those tumors can result in people living a long time, like many years. And so for someone who's well and has tumors of the right size and location, then that can be a great option.
Does that change if the tumor comes from the pancreas and it's an endocrine, slow growing?
So just to make sure I understood your question correctly. So your question is, what do we do if there's a cancer in the pancreas? That's an organ about here, which is a neuroendocrine carcinoma, kind of a less common kind of cancer to have in the pancreas, that's spread to numerous places in the liver but no place else? So one option, again, depending on kind of wellness and other medical problems, would be to try to shrink down the tumors that are in the liver, potentially with radioembolization. So radioembolization has been shown to be effective in neuroendocrine tumors that have gone to the liver. And if we got a great response, if a lot of them went away, then potentially there could be surgery in the liver as well. I mean, we do need to think carefully about how we're going to handle the pancreas tumor as well. I mean, pancreas surgery is big surgery. I mean, Dr. Eddinghausen would really be the expert, but obviously you need to sit down and review it with a physician if this is somebody that you know. But I think potentially there are options for someone who wanted to be aggressive. Well, so I wouldn't recommend stereotactic liver radiation unless we could get it down to just a few tumors. So if there are more than 2 or 3 tumors, I would become much more hesitant to recommend that. So I think the first goal, so if we wanted to do a lot of the things that Dr. Eddinghausen and I have talked about, I think the first goal would be to try and reduce the number of tumors. And Dr. Pine will talk a little bit about radioembolization, which might be the best choice. Well, yeah, so as long as we leave enough healthy liver, then the remaining liver should be able to regenerate and continue to provide the normal function it's always provided. Other questions? Please.
Between the radioembolization and chemo, when do you choose one over the other? Is there one that's more effective than the other?
So there are no comparative studies between radioembolization and chemoembolization, and Dr. Pine may touch upon this a little bit. Generally, in our cancer center, we've been deciding based on the likelihood of side effects. Most people get less side effects with the radioembolization than the chemoembolization. So when I sit down with a patient that we've treated with radioembolization a week or 2 later, mostly what they'll tell me is they've been a little tired, maybe they had a little pain in the liver for a couple of days after, and that was about it. They went home the same day and basically felt fine. A lot of people need to stay in the hospital for a night or a few nights after chemoembolization, and so we tend to reach for radioembolization first for most of our patients.
Is the process the same?
The process is similar. I'll defer to Dr. Pine to kind of go through the details in just a moment. Please. Right, so why do we do conventional radiation if we've got the stereotactic radiation? So the stereotactic radiation really depends upon us being able to give a whole lot of radiation in one treatment without causing problems. So that works well in the liver, it works well in the lungs, it works well in the brain. So those are all places where we can afford to, so if you look at this picture, right, so only the tumor is getting the full dose. But in order to get it done in 5 treatments and make it practical to do all the things that we do in order to do stereotactic radiation, we give about 5 times as much radiation per treatment as we would with traditional radiation. And so the consequence is that even the things that are getting like half the dose are not going to function in the future. So if that's just a little rim of liver and you've got all this other normal liver, that's really no problem. And it turns out that's true in the lung, that's true in the brain, ironically, and it's also true in the spine. But if you have a tumor that's, say, in the stomach or in the intestines, you know, even if it's only a little ring of your stomach that you've really severely damaged, that's a big problem, right? If a hole opens up there, that's going to be major surgery. It can be a major infection. So basically, we use the stereotactic radiation when the target is very well defined, when it's a specific round, doesn't have to be round, but a very specific tumor you can see very clearly on the imaging, and that is not located right up against something that we can't afford to kind of damage a little rim of around the target. So the other example would be like breast cancer. So after we take out a breast tumor, we radiate most or usually all of the breast to kill off the breast cancer cell that we know can be hiding other places in the breast. And you know, in that case, we're really treating what we can't see, right? If we could see a lump in the breast, we'd have taken it out. And so we really need to give small doses over many weeks to allow time for the normal tissues to recover, because there's no way to avoid radiating the normal tissues.